Hello there, I'm Dr. Thomas Martin from the University of California in San Francisco, and we're here today with Blood Cancers Today, discussing bispecifics and how we incorporate these new novel therapeutics in our treatment armamentarium for relapsed multiple myeloma, and I'm joined with several esteemed colleagues.
Hi, I'm Angela Dispenzieri, Mayo Clinic, Rochester, Minnesota.
Hi, Ajay Chari, recently at University of California, San Francisco as well.
Ajay Nooka from Emory University.
These obviously have some novel toxicities. We can start with CRS, et cetera. And that, Ajay just said that it mandates an admission, but does it, Angela? So tell us how you do it at the Mayo Clinic.
Yeah, so, we've been looking a lot at kind of remote monitoring where you kind of give a patient a box, of supplies for, blood pressure and heart rate and temperature monitoring. We do start all our patients currently according to the REMS, as an inpatient, but then when we dismiss them, we are in contact through the remote monitoring practice. There is talk that soon we are going to not be necessarily admitting all patients now for our bispecifics. Again, that's not exactly REMS, but so far, as long as we're kind of watching them for those first few hours and they're sent home with their monitoring and educated, to let us know if there's anything, because we have a very strong, we do outpatient BMT, we do a lot of outpatient hemonc kinds of things. Yeah. We have sort of 24/7. They don't go to the ER. They actually come to our unit. So then there's one less grouping that you have to train in terms of how to react. It's less about the ER physicians. They're all coming to our station. So, that's working. It's been working quite well, and we'll kind of see where it goes.
That'll be really interesting. So look out for a couple abstracts. So we have one here at SOHO, we have one at IMS, and we have one at ASH. And Elin from Mayo Clinic and I have been working with the IMF to try to do real-world analysis of tocilizumab. And it's very different the way actually it happens at Mayo Clinic, where they're outpatient, and with us where they're inpatient, which is really interesting. For us, we do admit them. We admit them for the 7 days. Dose them on day 1, 3, and 5 for the first 2 step-up doses in the first full dose, and then we send them home. But CRS management, as we talk amongst colleagues around the world, is a little bit different. Ajay, how do you do CRS management? How did you do it at Sinai, and then how are you going to do it at UCSF?
Well, there was an email about that, right? To standardize it for across all the malignancies, right, with the lymphoma and myeloma. Yes. I think so. We have to keep in mind that the dosing and schedule is going to be very different across the products. So currently, all 3 of these have step-up doses, 2 or 3 for TAL, depending on which dosing you're using. TAL has 0.4 weekly, which has 2 step-ups before final dose, or 0.8 every 2 weeks, which has 3 step-ups. So that is a longer hospitalization if you're doing it back-to-back. I bring that up because then Toci, being a monoclonal antibody, is a long half-life. So I think one of the things we're seeing is if you give Toci early, you have less recurrent CRS, and it probably can shorten that duration of hospitalization, because before you clear a patient for a subsequent dose, they need to have resolved the CRS. So if you give it, I personally am a big fan of early Toci, because the first fever, when you have multiple step-ups following, you'll just get, I don't like drama, right? Like squelch the drama early, pull the Toci trigger, and I think some people give Tylenol or acetaminophen with it. Some people also, I know, do Dex instead, and I think we had the CEVO, which is targeting FcRH5, not yet approved, but they presented prophylactic Toci that showed that the rates of CRS dropped significantly, but there was more neutropenia, and it didn't drop to grade 3 and higher CRS. So I think that's the concern with, I think clearly we'll hear Emory's data too, but I think early Toci personally for these. The only caveat I'll make is there are some other bispecifics being studied in myeloma that are weekly step-up. Yeah. There, I'm not sure how much Toci will help, because if you're not going to the next step-up for a week, you might get away with a little acetaminophen and Dex, right? So I think, but for now, for these ones that have tightly packed step-up, I think early Toci, I'm a big fan. I don't know if the group agrees.
So we've talked about this in our international myeloma working group meetings, and it really was split. split between those at early toci. Let's give them the toci with the first fever, try to take the fever away, especially as we do older patients where you don't really want them being febrile for multiple nights, because it does happen all at night. Then they get confused, then they get delirium, and then you're worried, is it ICANS, is it delirium, what is it? Turn it off quick, and again, then you have less recurrent CRS at following next doses. Versus the other camp that said, well, we can do DEX. Let's use DEX, and let's hold toci until they really have grade 2 CRS. So there really were two emerging camps. Anything different at Emory?
So we have started to go with Ajay, basically trying to see how can we minimize the risk of CRS getting worse, so by early incorporation of toci. What we have done as a practice measure with an intent to change to outpatient administration. So we looked at the first 15 patients that we treated. We looked at the median time to having a CRS. So that came down to 46 hours just prior to the second dose. So what we have tried to do is, can we prevent that from happening by giving toci 2 hours before? So at the 44-hour mark for the next 36 patients that we treated, we went ahead and gave the prophylactic toci. So which eventually turned out a third of the patients, 30% of the patients, 10 patients of these 36 patients had a CRS. All of them are grade 1. And there is no grade 3 toxicity, which is allowing us to say, if we give it prior to the second dose, you probably are minimizing the risk of a worse CRS. And the biggest concern that people against toci are, number one, it increases the risk of neutropenia, like from SIBO. Could it increase the risk of infections? So we looked at it very, very closely. Our data does not show that to be the case with one dose. And there is no higher grade toxicity with CRS. There is no increase in the readmit dates, and even by preventing an extra day of hospitalization, you offset the cost of toci, which is very cheap. So altogether, it makes case for us to do this. And right now, we have data for all these patients. We want to move to an outpatient setting. The caveats that we had in terms of why we did not move to an outpatient setting is we didn't have a 24-hour, 24/7 coverage like Mayo has, and physiological monitoring. So right now, once the AIC is open for us 24/7, it becomes so much easier for lymphomas, for myelomas, like all the bispecific antibodies to be treated the same way as an outpatient administration.
So some people have started to use prophylaxis, but that's a new twist. So it's prophylaxis after the first dose.
Yeah.
Is that right? That's a new twist. I like that.